for your support.
Thanks, Minerva.
Well, are we ready to go, Evelyn?
Yes, we're ready to go.
Good. Perfect.
Sorry.
Well, we have been slowly returning to the normality, or at least the previous time, and we were sharing information and spending time together. For today, I prepare a very basic presentation that I want to chat with all and share with all of you, and specifically give an overall view of what is dementia, and have some ideas what are symptoms, progression, and stage of the dementia. And at the same time, to talk a little about participation and integration as a caregiver, and how to minimize and to have a better outcome during the caring time. Well, dementia, and the definition, carry multiple cognitive deficits, but the most common one, if you go and ask people, you walk on the street and trying to do interviews, the most common symptoms that the people will respond to you is memory loss, because this is a characteristic disease that carry memory impairment. But be careful. Many times dementia start being noticed not just by memory impairment, if no, can be by aphasia, apraxia, and nausea. They are all neurological disturbance of the brain. And if you pay attention, a few weeks ago, the family of Bruce Willis came out and published that Bruce won't be able to act any longer because he has an aphasia. And we don't know the reason. There are many different disorders that may provoke aphasia, but one of the most common ones is to develop dementia. And in addition to this, there are problems with executive function. And then, what is really dementia? Because if we are going to be working in this, and we want to understand and perfection ourselves to perform appropriately, dementia is a deterioration of the mental functions. But please don't allow people to confuse dementia with age-related situations. Don't allow people to say, well, you lose a lot of memory when you get 80. Therefore, you may be losing memory, but be careful, because it's more severe than any aging process, the process of dementia. It's impacting in many aspects, but the most common one is in activities, familiar, socials, and how you integrate in relationship, and it's progressive. Let's start the morning saying it's progressive without treatment. And in memory, what is memory? Well, memory is the ability that we have to store and retrieve information. I share with you a few minutes later, you share back with me, and we continue in a conversation. When you have dementia, you have deficit in memory, and you have deficit in storing the memories. And in this case, it's the short-term memory. Therefore, a minute and a half later, you will be asking me the same question a minute before, because there is not the storage at all. It's just enter and go, and there is not the storage. And this is how we present the situation and how we learn how to deal with all of the individual. A little of criteria diagnosis. In this case, we use but the final diagnosis. And a little, I want you being aware that there are different types of dementias. This one of the common questions that came to me is, Dr. P, I want to know if my mother has dementia or Alzheimer's disease. And this is a common conversation of the support group, or people asking questions, or people sending me a message, always with the same question. Is my mother or father having Alzheimer's or dementia? And well, the answer, as you can see, is very easy, because dementia is the neurological disorder, but there are different types of dementia. And the most common one, the one that is the clearest majority, is Alzheimer's disease, with about 60 to 62% of the dementias in the United States. And then we have cerebrovascular disease, we have Alzheimer's disease with Parkinson and Lewy body dementia. We have peak disease called frontotemporal dementias, and other type of dementia that appear, and that we need to take into consideration. A common one that I see very much later on is alcoholic dementia. Chronic alcoholic individuals develop dementia process. They have an accumulation of symptoms similar to dementia of Alzheimer's type. And how we start learning the clinical course of the disease, how we think that the symptoms are coming into the picture. Well, at the beginning, there are some memory lapses, in which one you notice as a patient with the disease, as an individual, as well as some of your family members may notice, and they probably make comments. In general, when comments are made, the initial part of the process is very difficult, is very much in a denial process. They jump immediately and say, no, I have a better memory than you. I don't need anything. Then we start noticing that they have some difficulty performing very familiar tasks. If it's your mother, well, for some reason, she asked for a little support how to handle the microwave oven because she forgot one step. Or she will ask you another question about something that was very familiar with her before. And here is when we have the aphasia, and which one we call word finding difficulties. But this is the aphasic component. And look at this, aphasia can be in a form of not finding the word that you want to say, and it's called expressive aphasia. It's what you talk, your word finding difficulty, versus receptive aphasia. You talk to me and I am unable to capture the 100% because I have receptive aphasia and I am missing portion. And you know how people get confused with this? The confusion is my mother or my father is having hearing problem. Hearing problem is a part of the deafness situation in which one you don't hear. Receptive aphasia is you hear, but there is a missing link on the change of your statement, on the change of your phrase, and you miss it. Therefore, you get more confused. Therefore, the family say, Mom, you didn't hear what I said to you? You didn't get it? See, Mom needs hearing aid. We need to be very careful in differentiating what is receptive aphasia and expressive aphasia. Little by little, they start having difficulty with orientation. Therefore, it's a little more difficult for them to move very relaxed in spaces that they has been with commodity before. They get kind of lost in familiar places. Many times occur during the night. They get up during the night to use the bathroom, and then they get lost on the house. They end up sitting on the living room and not knowing exactly how to go back to the bedroom for a little while, or they call and they need some support. They have difficulties with judgment and with some decision making. Think that they were doing so easily before, are all involved in with some change of personalities and having difficulties. All think this get on the way on the relationship of caregiving. Together with this process of deterioration of cognitive function, we have behavioral disturbance. Will be very easy, or will be easy to be a caregiver if we won't have the behavioral disturbance of an Alzheimer's disease. And those behavioral disturbances are characterized specifically by psychotic symptoms, that we will see it briefly, by apathy, is removing, isolating, not wanting to participate, disconnected from the environment, by agitated behavior, the difficult to control, in which one we need to reach out for help because it's difficult to manage, by irritable affect, in which one the patients change in a few minutes from being happy to being frustrated, and is where agitation and anxiety peak. Inappropriate pattern of activity, such of them are escape from the house, other act sexually inappropriate in public spaces, others do activities that are not that they never learn about those activities, and they just get involved in them. And there is depression. And depression, like any one of them, should be treated. What is agitation? Well, agitation can be interpreted as someone who moves constantly. There's appear trapped inside a room, that they are checking the doors, and some of them check the door and the exit sign at the same time. Therefore, you have a combination of wandering, psychomotor agitation, and fear for escape, because if they are look at the exit, it's because they are looking through an easy way to get outside. And there are many of them that at the same time they become agitated, they increase the verbal output. They scream a little more, they become very loud. And it's very closely related to the cognitive impairment. There is an inverse relationship between being agitated and the age that is documented. Well, with this, I am trying to share with you the youngest demented individual they are more prone to agitation than the oldest individual with dementia. Irritability is something very common. It's something that we use in our evaluation of individuals. In a certain form, I use to define what might be a pre-morbid aggression. This is coming around. It's something this I discuss with the family and say, look at with this degree of irritability, with this condition of not understanding well what is going on. We have a combustion. This may create some violent behavior later on. We need to be aware. But if this irritable affect associated with violence is one of the number one marker that impact the rate of institutionalization. These are the patients that have to go into a nursing home or an assisted living unit or another place before others due to the behavior. What are inappropriate partner of activities? Well, there are simple ones that sometimes you smile with them, like collecting sugar papers, collecting little things on the dining room and taking everything to them, with them, to take it where they are located. And in this form, the thing is there. The thing is easy to control. It's buttoning and unbuttoning the clothing, and specifically in here is where appear what is the terror of facility such a nursing home in assisted living facility that they call desperate because the patient displays some sexually inappropriate behavior. And we see those. Depression. Remember, approximately 50% of the individual with a diagnosis of an Alzheimer's disease have an associated depression. Might be a major depression, might be just a minor depression. But you know this is very important to treat the depression. The association of depressive behavior with Alzheimer's exacerbate the cognitive impairment. This means the cognition will deteriorate more rapidly if you don't treat appropriately the depression. What do we do in order to proceed when someone is coming to us? Well, I have a subspecialty. I am a geriatric psychiatrist. There are some insurance that they need a referral from a primary care physician in order to come to see me. There are others that you can just choose the visit and come. We initiate with a nice collection of medical history. We're trying to get as much information. I have interviewed with the patients at the beginning. going as far as possible. Then if the patient authorizes me, I invite the family. I pick a lot into social history, what has been the past of this person. I try to give a shape to this, like I have this human being in front of me. This appears to be deteriorated in what he can communicate. But he has 75 years of his life living with family, working, social activities, performance, anything. And please give it to me because I am giving shape to this person. We do mental status examination, reviewing what happened with his way of thinking, as well as what we call a mini mental state examination. This is where we pick a little about what happened with memory, judgment, rationale, and kind of location in orientation. We have physical self, maintenance scale, sometimes the family health, neurological examination if it's indicated. We do psychological testing if it's indicated. In general, I base a lot of my report and psychological testing when you have to go to court, when you have to fight different type of legal actions with the elderly. EEG and brain scan, I do CAT scan often, sometimes if necessary, an MRI. And well, here we go. Here we have this disease, and clinically, in how we move, I prefer to simply sharing with you how we divide the stages. And we say, these are the stages of the disease. There is an initial mild, can go to 2 to 4 years. There is an intermediate or moderate, this go 2 to 8 years. And there is the advanced one. This in general is year, year and a half, 2 years. But that is how the stages move. Well, in the initial, you will see how the symptomatology increase stage by stage. And the initial or mild stage, they repeat the same thing over and over because they cannot collect the memory appropriately. They get lost easily. They start losing interest in tasks they once enjoyed. They are having difficulty playing bridge or playing canasta or any other game with the family, and they start retracting and say, oh, I'm a little tired. No, last time I didn't even enjoy it. They have trouble finding name. This is word finding difficulties, and it's specifically what we call, this is a expressive aphasia. They lose things frequently. This is the stage in which one they start having difficulties finding the keys of the car, like we all have problem finding the keys of the car, but they get very stressed. There are personality change, and specifically, like I said before, there are very much depression. They get a little panicky. Sometimes they come to you, not because they are losing memory. They are not coming to visit you because they believe this may have dementia. They are coming through another door, the door of being depressed, anxious, and panicky. My mom doesn't want to drive on the highway anymore. She just wants to go a few places in which one she doesn't have to get up on the highway. Why? And you start talking and you find this, there are difficulties in orientation and difficulties in how they accommodate. They become fearful and panicky. What happened at the moderate stage? At the moderate stage is more confusion. I will tell you that the beginning of a moderate stage is being more irritable. They are more defensive. They start changing as a person. It's not your same husband. It's not your same mother or father. The person are changing a little. They present with difficulties and a lot of resistance to be helped. Therefore, they have difficulties dressing and telling you right on the face, I know how to do it, and blah, blah, blah. And then you look and you see that they put the shirt first and the t-shirt on the top. And you don't say anything because if you say anything, it's going to be an argument. A few months after the intermediate or moderate stage, they start with certain creation of suspiciousness and false belief. Some of them by comment or situation that didn't occur, such as last night, you know who came to visit with me for a few minutes. No, my brother George, and you don't want to say anything. You don't want to confront them. You don't want to say to your person that you are caring, George died 2 years ago. You just have to beat around the bushes a little and try to calm them down. Some of those false beliefs project into almost a degree of suspiciousness. This male, we act different than female at this stage. The female is more accusatory of think disappearing and being steal from them. And in general, the target violator, the criminal the women appoint is another woman. Is in general, she took my jewelry. She is getting my shoes away. Those kind of things the family kind of horrified come to tell us. Nobody came, nobody took anything. We found her ring under the mattress because she hid it there. And we male are more, our suspicion is more projected inside the family. One of the most common building suspicions that we have as a male is the loss of freedom, the loss of independence. And together with the loss of independence are coming my boots, my truck, the ranch, any of those things that has been inserted on you as a florid independent, the thing that you like to do. And who are you going to blame? Well, poor family, those with many daughters, because it's wife and daughters. Always is a female figure, wife and daughter. And they want doctor, I never saw them doing anything, but I know that they have in mind to sell my truck, to put me in a nursing home, to sell the ranch, to get the money. That's a male projection. Psychomotor hyperactivity, they walk around, they become irritable. Sometimes they try to escape. There is some insomnia and lack of appetite. And then we go to the severe stage. And clearly, individual cannot do things on their own anymore. There is no possibility to have commanding word because they cannot process anymore. No longer able to recognize their self on the mirror. Therefore, they become extremely agitated when they see their self on the mirror. They assault the mirror, they punch the mirror. Therefore, many of you, this has been working with me for years, we are very careful with having a lot of mirrors on the home. We want to minimize this, just keep it on the background. Don't have it around because they have a very poor reaction because they immediately understand this is a strange person looking at them, and they have an overwhelming reaction of anger and agitation. They don't recognize family members anymore. I think a husband and wife are the one who keep in memory the longest, but sometimes they ask, who are you? And it's very difficult because you are in a process almost terminating a relationship that has been your life. With a person, this is not terminating with you because honestly, they cannot communicate, they cannot be with you, and it's very difficult. How we manage this disease? Everybody knows this. We don't have cure. Everybody knows this. We have available medication that through the year has been part of the frequent attempt to discover a curative medication. But honestly, we don't have any. Therefore, I like to call it how we manage this. How we can continue providing quality of life and care to those individuals when we don't have much available. And then when I define management, I say, well, we have something pharmacologic that I share with you. We have behavioral intervention, case educating ourselves and talking like today and see how we are going to react. And I will be open for your question, asking me how to intervene. We have family support and education. And overall, becoming, in my role and in the role of you caregiver, becoming a center, a modality of integration between the primary care physician, the family, this one, the home health agency, they went to hospice, becoming a little desk center in which one organize a little the information in how this moves. When I refer to this, it's very important to have communication with the primary care physician. A frequent review of plan of care. And I see my patient if they are stable, maybe every 3 months. And they always come with a family. Sometimes I like it because they even come with one of the care worker or providers. And we sit and we check the vital component of the treatment. How is this doing? The symptoms, the agitation, the appetite, the sleeping, the taking the medication, everybody okay? And then we use about 10 minutes to review the plan of care, because I point to them that there are some progression in the disease, that he is a little more repetitive, that he responds less, that he choke when you give food. And there is a frequent review accommodating a plan of treatment in someone who is progressing, is not stable, is not fixed. I used the same time to share and to answer questions that they have about community resources, because they come with questions about when do you think, Dr. P, this we will have to put my mom in a nursing home? What areas you believe that we need to take in consideration? We have little conversations about when you put someone in an assisted living unit, how you measure the surrounding of where are you going to put your loved one, how you trying to balance the level of participation of your mother is equal at the rest on the unit. Because if you put your mother in a memory unit, everybody perform lower, the most common thing will be the century week. Your mother will be performing lower, accommodating to the dynamic of the environment. Now, if you put your mother lower performing in a higher, there is possibility that she will pull up and enjoy it, or that she will be isolated for not being able to fit there and become agitated and aggressive. But those are things that we monitor and we take into consideration. Always keep in mind that we need to be helping everyone in counseling for legal and financial issues, because it's something that appears to be always running late. It's always running late. They are coming to see me in a moderate stage of the disease, and the person has difficulties understanding what is going on, but there is no power of attorney, there is no guardianship, there is no legal instrument that can really facilitate the process of caring that we need. And it's something that I am not a lawyer, but I always make recommendations. We have resources on the community. I always work with all of the lawyers in town, preparing guardianship application, helping them, doing evaluations of capacity, going to court and testifying for them. And it's very, very important, very, very important. And always we discuss what support has the family. We make referral and close referral. For the last, I don't know, Marianne can correct me, but for the last 7 or 10 years, my close relationship with what made charitable organization, as well as all of the SOS, caregiver SOS. We have been working so close that we make recommendations, referral. We know and learn every day about different resources, and this is what is helpful to us. How we can conclude? We will say there's an early diagnosis and treatment is important. Some people, including colleagues of mine, make sarcastic comments in my face about this. What do you gain with an early diagnosis if you don't have a treatment? What do you gain with an early diagnosis if there is no cure? But well, my answer is a little smooth and saying that an early diagnosis and treatment prolong the time for you to prepare an appropriate package to offer quality of life to someone who suffers dementia. Therefore, it's always important to know from the beginning and to be offering and preparing families and caregivers. It's important to separate what are the cognitive and non-cognitive deficits. It's important to work with some agents like there are medications that are not curative at all, but may improve a little, such as Aricept, Exelon, galantamine, and separated from non-cognitive deficit, in which one there is remarkable anxiety, feeling of panic, insomnia, and the number one, to be depressed. It's an obligation from us to talk about those non-cognitive deficits, but to try to improve, because accommodate the quality of life of individual and give a very better quality. I am very dedicated to teach what is the balance between supervision with a mix of meaningful activities, independence and freedom. I always want to have my patient, the one that I care for, utilizing the maximum of their ability without having the old medical model. You have a fracture of your arm, I take care of you. Oh, give me, I sponge back to you. Perfect, that's it. No, the patient with me, no. You have one arm that's work well, you sponge back yourself. And then I will help you with this arm. And the same at the cognitive level. Don't jump and just feed it. I look sometimes at individuals that they place the tray in different places and they start feeding. And I say, can I do it for a little while? And I go and I reaccommodate the tray a little and I give the fork and I say, go ahead, I will spend some time in here with you. And very little, very trembling, very messy sometimes, but you know what? They eat all of the food. And when they finish, they want the fork to mix the orange juice. And you don't say, you don't do this, yeah, please, no. You say, okay, give me the fork, I will give you this, and I give the spoons, and you can mix your orange juice. It's okay. And they try to mix your orange juice with a coffee, and I say, oh, no, that tastes horrible. Just drink it here or put it there. And I mean, it's a guidance in which one you finish with little inversion of time, you obtain excellent interaction with the individual and open some channels of participation. These are very important, very, very important. We always educate and advise regarding treatment intervention. We try to look for clinical plateaus in which one or manage work well with the family and caregiver, and the patient stayed for longer time. Family sending me picture last weekend of a grandma turning 79 under my care for 10 years, turning 79, entering the advanced stage, but quiet, walking around. Sometimes I do home visit for her, declining, taking her medication. But Saturday was her birthday. And because families get together, and they got together and they barbecue and then music, and on the middle of the music, my patient started dancing non-stop going around, happy. Yeah, she was disturbed because they were taping and picturing her, and she was like, no, please, no. It continued dancing, and they sent me pictures, and it's the most wonderful thing. It's beautiful because this is managing the disease. We cannot cure, but we can have at least support someone for them to have a very important response. Let me talk to you a little about what are the pharmacologic agents. There are 3 drugs available that we use in Alzheimer's disease. Is donepezil is called Aricept. Rivastigmine is called Exelon, and Exelon is coming in pills, liquid, and in a patch, dermic patch. This works very well, specifically for patients that become resistant to take medication. And there is another component. This is called memantine. This combined well with either one of these three and give in certain way a little of refreshment to the person. They become a little more attentive. Some of the behavior get corrected. And in a certain way, they appear to observe more the surrounding. They start asking for combination of colors. They don't want just to be dressed up in a quick way and don't pay attention to what I want. Therefore, we pay attention to all of those things. Now, on the other hand, for non-cognitive treatment of symptoms, we have antidepressants. We're trying to select those that are mild because we need to be careful with side effects of the medication. We try very low and go slow. This is the motive, and this is how I teach residents and medical students. We go low and slow because we want to prevent any side effect. And at the same time, when you manage medication, you need to educate or partially educate your patient with poor cognitive function and a lot of education to the family. And there are some steps in how I share with all of you caregivers. And as one, if you are going to do whatever you want, you don't need me. And that doesn't sound like a super bossy, but they respond so well. And you pay some price for what you say because they will call you more frequently. But on the other hand, I almost don't have any family member or caregiver. They just go and say, no, this medication, I remove it. How long ago? Oh, yes, 10 days today. And you never say anything. Oh, no, this medication doesn't work. I don't hear that. I think it's a good combination. And that's the time that I take to teach them. You look at this, they are drooling, you stop the medication and call me. And they are sleeping a lot, you decrease the medication and you call me. But it's important with pharmacologication because on the process of dementia, it's such a difficult situation, the business of medication. You start with the patient is in denial and they don't need it. You continue with the patient is taking the medication and having some side effect. You continue that the patient shows some side effect and your associated family, you're the caregiver, but your associated family is crucifying you because you are not able to discontinue this medication. And the person has to say, well, let me talk to the doctor. And we talk and we adjust. And when we are on the center of a moderate stage, they start spitting the medication. They don't want to swallow. They don't want to swallow at all. And the associated family, they were so critical at the beginning. Now we need all of them to give the medication. They are gone. They are gone. Therefore, we crash some medication and giving with food. We create little tricks. They teach me tricks. And then I transfer and tell another family of the trick. And they believe I know everything. No, I learned from you guys too. And we transfer information. But pharmacology component in the management of the illness is important. It's not curative, but it's important. And 1 minute in behavioral intervention. It's incredible that we are going to care for someone who have a cognitive illness, and we are not going to understand the ABC of a dementia. Don't push, because it's not a matter of pushing. Look at this example. Commit yourself to work and think as if I have a fracture of my arm. They are going to put a cast, or they are going to operate it, and they are going to put a plug and some screw, and it will be immobilized, and you are my caregiver, and you help me in any aspect, including I dictate note, and you type it for me because my right hand is disabled. And 2 months later, they remove the cast, and I start going to PT and OT, and here, and 6 months later, you don't even know which one was my broken arm. Perfect. Now, you're taking care of a continual progressive loss of cells on the brain. It's like this. And what are we going to do if we cannot prevent it? There is nothing to detain the process until now. Well, what we are going to do, and quickly, to focus on the all healthy cells of the individual and take the best out of this. Therefore, one thing is rehabilitation and another is habilitation. I am going to teach this, my philosophy of caring for you is going to extract the maximum of your good self. Let's talk to me, do reminiscence, look at picture, go to movie, learn a little about medication, and if you are agitated, back off, and if you don't want to eat, I come back in 5 minutes. Why? Because the doctor said they don't have an idea that they refused 5 minutes before. They don't remember, and now they eat. What is going on? Okay, but this is habilitation. And that's what I want you dressing of habilitators at the point of behavioral intervention. You never say no, you never say don't. You never say sit, now, prohibit words. All of them crash inside of a disabilitated brain and create disasters in the consequence and in the response of individuals. We always say, Mom, look at this, look at this. Mom, let's go and have a cup of coffee. Mom, no now, no now. Yes, and always distracting, mobilizing, moving things around until we have a better response. Well, Emily, we are going to, I don't know in here, how to remove stop share. Wow, Evelyn, I did it. Yeah, and now I am ready for all of you, any one of you, to have your questions and we chat. Wow, I am very excited and happy this. There are many of you. Thank you for coming in on Tuesday, and sure that you will be sharing good things with me. Let's go. Go ahead, Anani.
Okay, folks, the good doctor is going to take your questions or comments now. I think, because of the time, we have 3 minutes left till the hour, but we'll go over a little bit because I know Mary Ann, who works with the doctor, also has some announcements to make. So go ahead and open up your line. If you're on the phone, just unmute yourself by pressing *6, or you can unmute yourself on Zoom and we'll be able to see that. We'd love to have you join us to ask your questions, get them answered by, obviously, a spectacular expert.
Questions.
Come on, folks.
You have to unmute yourself.
You can do it by pressing *6 if you're on the phone, or just unmute yourself.
No, I'm talking to Sharon.
Oh, Sharon. Let me see if I can do this. there.
I did it. Yay. My husband had surgery, 9 hours of surgery. And when he came out of it, he was in severe dementia. He didn't even know how to dress himself or anything, and he's gotten better. But he still has it. And I'm wondering if the trajectory of this is going to be any different, because of the way it started and then it got better and now it's sort of like in there, and I'm wondering about that.
Sharon, what a question, Sharon. Your question is academical, is of every day. Con student, with resident, with other colleagues of mine, with the anesthesiologists when they go on the operation, with the time spent on the OR. In a simple answer, Sharon, is what happened during operation time. They take us into the OR. We go under anesthesia. In general, the surgeon doesn't like high blood pressure because bleed all over.
Mm.
And they have a more cool, quiet, very cool place, the OR, and they decrease the blood pressure. They create a little less blood perfusion to the brain, specifically to an aging brain. And when we wake up with a little delirium for 1 or 2 days, and then we lost several points of cognitive function. Honestly, I see daily individual that has been in a mild stage. They has been degrading, but not much. They go for a fracture of the hip and they come out in the center of a moderate stage. I saw individuals that were eating by themselves and they come out and they don't know what is the fork. They don't know what to do with the fork. Now, to follow, Sharon, your very, very pointing question is how much they recover and return to the past. Sharon, not much. Not much. If they lost, because we count on point making a test, if they lost 4 or 5 points, they may recover 1 or 2 at the best, but the majority of what is lost and there's trauma, impacting trauma, is going to stay there.
Okay, so if he would have to have surgery again, is that, we've tried to avoid that, like prostate and things like that. And so we wonder if he is to have even a short surgery again, is that going to affect him more?
It might be, but today, Sharon, you have another tool in your hand. The day they schedule surgery, you ask that you want to talk to the anesthesiologist. And you said the other time was a little bumpy road. Do the best for him, not to be running very low. And we will do the best with the surgeon to make it short. But there are times, Sharon, days we have to go with the surgery.
Yeah. They might have to, yeah. Yes.
Thank you. Wonderful question.
Yeah, thank you so much. Mary Ann, do you want to go ahead and make your announcements and then we'll take another question?
Okay, Dr. Praderio, you have a question there on the chat while I do the announcements. Dr. Praderio will be holding a Healthy Aging Forum. He's going to be speaking on the perspectives on aging. That's going to be May the 18th, Wednesday, May the 18th, 8 to noon. And that's going to be at the First United Methodist Church here in Corpus Christi. And then we are also planning on the face-to-face festival, late August or beginning of September. We will be posting the date as soon as we get it. And we'd also like to invite you all to join us for the Walk for Memory, November the 5th. And it's going to be at Waters Edge Park. And that one will also be available virtually. So please join us. You can, if you want more information on Dr. Praderio, it's going to be texasfacetoface.com, or he's also on Facebook, Texas Face to Face.
Mary Ann, will you send me a flyer so that we can include it with the resources that we send out to folks after the session?
Yes, ma'am, I will.
Okay, that would be great. Thank you. Okay.
Thank you. I open there is one of the questions that came to me. But when I opened in here to answer the question, I found people from all over. I have some of you from Miami, Ohio, New Jersey, someone who born in Corpus Christi, Danessa, and she joined us. Where are you living now, Danessa? Well, and here we are with a question. My mother-in-law has some downers. It does consider mild dementia? First part of the question. She seemed to have symptoms of mild to moderate dementia. She has episode of violence. The answer goes to Noreen. Noreen, yes, sundowner is the deterioration during the evening. We don't use the term professionally anymore, but there's deterioration during the evening of individuals that start becoming partially delirious. And they start seeing things, they are having some perceptual disturbance, visual hallucination, very agitated, and there is a high probability that this is associated with a dementia. Therefore, yes, my suggestion will be to resource to take your mother-in-law to be seen, and they help you with it. Okay.
Great. Anybody else have one more question?
One more question.
Doctor, I can't thank you enough. You've done such a beautiful job. As you
Adelaide.
always do. Yes, you're so practical. It's so understandable. It's just great. I'd also like to thank the WellMed Charitable Foundation. I want folks to know I'll be sending you the Elder Care Locator resource as well as Mary Ann's brochure for some of those fabulous events that they're planning with Dr. Praderio. And I also would like to thank the WellMed Charitable Foundation for sponsoring these fabulous events for us.
Like always, Evelyn, thank you and good luck.
Thank you so much, Doc.
Bye, guys, all of you.
Bye-bye, everybody.